Hi everyone, this is Lola. I'm the Harvard site coordinator for the Beth Israel Deaconess Medical Center site for the New England Mental Health Technology Transfer Center. Please feel free to introduce yourself in the chat box. Now, I just want to review a few housekeeping items before we begin. Next slide, please. Participant microphones have been muted at entry, and you will be able to unmute them during the discussion portion. During the presentation, if you have any technical difficulties or questions about the topic, please use the chat box. The webinar is being recorded and will be available for viewing at a later time on the MHTTC website. If you'd like to reach us after the webinar, you can email newengland@mhttcnetwork.org. Next slide, please. These are some acknowledgements for MHTTC. Next slide, please. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and lastly, consistent with our actions, policies, and products. And with that, I'll hand it over to Raquel for introductions.
Thanks so much, Lola. And good afternoon, everyone, and thanks so much for joining us today. My name is Raquel Meshalem Gately. I am a psychologist from Beth Israel Deaconess Medical Center in Boston and the co-director of the Beth Israel site for the New England Mental Health Technology Transfer Center. So with that, it is my pleasure to welcome you to today's webinar, which is actually a joint webinar between the Massachusetts Mental Health Center, Grand Rounds, and the New England MHTTC. So I am absolutely delighted to welcome today my colleague and mentor, Dr. Matcheri Keshavan. I am going to give just a very brief introduction for him because if I tried to list all of his accomplishments, we'd be here a very long time. So Dr. Keshavan is the Stanley Cobb Professor of Psychiatry at the Beth Israel Deaconess Medical Center and Harvard Medical School. He is also the academic head for the department and director of our Beth Israel Deaconess site for the New England MHTTC. Dr. Keshavan is closely involved in research in the neurobiology of psychosis, especially as it pertains to first episode psychotic disorders, and he is a board-certified psychiatrist. And today he is going to be sharing his vast expertise regarding psychosis. So with that, I will turn it over to you, Dr. Keshavan.
Okay, thank you, Raquel. Hope all of you are doing well in this era of the triple pandemic and hope you're all staying well. I'm speaking on the topic of early psychosis because that is an area where I have focused over the last 30 years, both as a researcher, understanding the biological basis of these disorders, as well as taking care of these patients. And I work in a first episode psychosis clinic called Aspire at Beth Israel Deaconess Medical Center. The point of this talk is that there is an art and a science to taking care of people with serious mental illness. I'm focusing on the early course psychosis, but the kind of principles that I will be talking about would be of relevance to psychiatry generally. And I would be interested in any thoughts and input at the end. And I have a few too many slides. I may go a bit fast, but if you at some point want to ask a question, please feel free to use the chat box. So first of all, why is early intervention in psychosis so important? First of all, this is a population that is vastly undertreated. And it's also a treatment, it's also a group with a high treatment need. Nearly 2/3 of the cohort at least one hospitalization and at least one emergency room visit during the first year of care. And there is a high mortality in this illness these illnesses due to suicide, overdose, and accidents. There are also diseases like schizophrenia lead to a reduced longevity of about 15 to 20 years, shortening of life expectancy due to high rates of comorbid medical illnesses, as well as high rates of loneliness, and also, as I mentioned, suicide, overdose, and accidents. Now, here is a quote from a well-known medical writer and scholar, Siddhartha Mukherjee, who made the point, in his book called The Loss of Medicine, which was published a couple of years ago. Psychiatry is still more of an art than a science. And he said, my medical education had taught me plenty of facts, but very little about the spaces that live between facts. And most of you clinicians will agree with me that a lot of the approaches to patient care that we picked up over the years are not those that we learned in medical school or other training programs. And these are experiential. So in this talk, I'm going to focus more on the art part of taking care of severe mental illness. But of course, I'll also sprinkle in some scientific facts that go with those. Now, these are the key points that I'm going to cover. The art of taking care of a person with illness involves developing a therapeutic alliance. If some of you have not muted yourself, please do so. The art of the therapeutic alliance, I'm going to make the point that having a positive therapeutic alliance is one of the key aspects of positive therapeutic outcomes in mental illnesses generally, and there is evidence for that in psychosis in particular, and so on. There is also an art to sharing the diagnosis and sharing the prognosis with patients and his or her family. Decision-making in terms of treatment is best accomplished by an approach to shared decision-making, which is also part of the art of care. And then there are a number of principles of thinking about how to implement good psychopharmacology, and I summarize them as the art of prescribing. And finally, there are the key issues of tailoring the treatment to the phase of the illness, especially given that chronic psychotic disorders like schizophrenia are characterized by multiple sequential phases: the prodromal, the psychosis, the acute psychosis, and the chronic stable phases of illness, and so on. So those are the key points that I'm going to be making. First of all, about therapeutic alliance. The essential importance of therapeutic alliance is that the alliance is the centerpiece of treatment. The prescribers know about the medication and doses, whereas the patients know how they make them feel. So it's the two of the treater and the patient together form a group that is a tremendous collaborative opportunity in all of medicine. And together, the doctor and the patient find their way through appropriate drug dose and side effects and so forth. There are three main components to therapeutic alliance. There is the therapist-patient agreement on the goals of treatment, and the therapist-patient agreement on what specific interventions there are, and finally, a trusting bond between the patient and therapist that involves trust, respect, and acceptance. These are the three pillars of this concept called therapeutic alliance. So just let me illustrate to you an example of the challenges in building a therapeutic alliance and approaches to address therapeutic alliance or build a therapeutic alliance in clinical practice. So this is a young lady that I saw many years ago, 22-year-old woman who had been brought for gradual social withdrawal, talking to herself, believes that she is the messiah designed to eliminate poverty around the world. She had dropped out of an engineering school because of failing grades, and disinterest in attending classes. So when I saw her first, she denied all psychotic symptoms, but admitted to being unhappy about dropping out of college. She could not pay attention to classes because her mind was cluttered because of the chatter inside her head. She did not believe she has an illness, and she refused all medications. So there are three options. What do we do? Now, number one, refer her to your colleague for psychotherapy. Number two, tell her that she has a psychotic illness and she needs antipsychotic treatment. Number three, explore ways to explain her illness that make sense to her. So any thoughts, please put in the chat any answers that you all think is the approach that you would use. Any thoughts? I'm not able to see the chat on my computer. Raquel, maybe you can see and let me know. Let's see.
Sure, it looks like people are giving a variety of responses here. It looks like 3 is the most popular.
Yeah, and 3 is the answer that I'm going to argue is the correct answer. So in this particular patient, I took this following approach. In the second session, I engaged her in a conversation about why is she dropping out of this Ivy college? She said she's interested in graduating but had dropped out. And she said, I can't concentrate in my classes, and my mind is too cluttered, and I can't concentrate. So I really am not doing well in school. So I asked her, what is she studying in college? She said she's studying radios and transistors and so forth, and she's an electrical engineer. So I asked her, think about, the radio as an information processing system. What happens if the radio is not tuning right? She said if the radio is not tuning the right station, it gives you a lot of static. And if it is not picking up the signal, it gives no sound at all. So I asked her, if you think of your brain as a information processing system, and if it was not perceiving information and you had static, how might that static feel to you? And when you said to me that your mind is, chattering away, and you hear these voices, whispers inside your head, do you think that might be because your brain might not be processing information sufficiently, and so there is a lot of static? She considered that as an acceptable option or a possibility. And then I explained to her that there is this neurotransmitter in the brain called dopamine, which really regulates the sensitivity of this information processing system. And it turns down wherever there is excessive chatter and turns up the signal wherever the signal has to be sharpened. So would you be willing to consider a medicine that readjusts your dopamine in your brain and thereby, improve your information processing so that you can study back in school? So the main point, and she was willing to accept that, and she agreed to take some risperidone, and she felt better. The point is that it doesn't help to tell the patient they have schizophrenia or a psychotic disorder if they are not willing to accept those terms. So we will have to develop a way of tuning into their own models of what they think might be an issue, and also identify what they see as a problem that they recognize and acknowledge, and develop a partnership around a problem that both she and you would agree. And that principle, which was articulated by Xavier Amador, who's a psychologist, in a classic book called I'm Not Sick, I Don't Need Meds. He used these principles of what he called listen, empathize, agree, and partner, or the LEAP principle. Xavier wrote this book based on his own experience working with a brother who has schizophrenia, and he teaches widely on these principles. And if you haven't read this book, please consider getting a copy and reading it. It's very helpful. So let me show another case in terms of which brings up the importance of therapeutic alliance. This young lady was treated successfully for 2 psychotic episodes with paranoia and auditory hallucinations. She was symptom-free for over 3 years, and her risperidone had been brought down to a maintenance dose of 2 milligrams per day. And then she wanted to move to another state for a better job and to discontinue her medications. Even though I recommended a small maintenance dose to continue, she was not willing. So what are the options that you would consider in someone like this? Number 1, continue to treat her long distance. Number 2, discharge her and ask her to follow up with a local psychiatrist. Number 3, discharge as needed by her, connect with her with a local psychiatrist, and also ask her to contact you if urgently needed. So again, please use the chat box to tell the group as to what you would do. What would be your choice? And Raquel, tell me what is the main or most popular response.
Sure, it looks like option 3 is the winner again this time.
Yeah, exactly. That's exactly the point I want to make. Option 3 refers to the key point of maintaining therapeutic alliance. So 2 years later, I got a call from this young lady who was in an airport reporting that she had suddenly begun hearing voices from a nearby air conditioner. I had never heard back from her for 2 years, but now she calls me from the airport. She had not seen any clinician in the states she was in Nebraska. She wanted to get back on the risperidone as soon as possible. And I had told her that she could keep a small sample of risperidone tablets in her purse, and she had promptly kept that. And I asked her to take it and go to the emergency room and make an appointment as soon as she could, and she promptly did. So the key point is, not only is it important to develop a positive therapeutic alliance, but also maintaining it. Maintaining therapeutic alliance, even in patients who you don't regularly see any further, even if you have officially discharged the person, I tend not to completely, lose connection, and giving them that option of being reachable in emergency can be a lifesaver quite often. Now, this is a classic paper by a colleague of ours at Harvard, who unfortunately is no more, John Ganderson, who did this classic study several years ago, in which he looked at the outcome of people with psychosis, with the first episode of psychosis, and looked at whether therapeutic alliance could predict outcomes. What he found was that patients who formed good alliances with their therapists within the first 6 months of treatment were significantly more likely to remain in psychotherapy, to comply with their prescribed medications, and also achieve better outcomes with less medication than patients who did not. So it's just to highlight the importance of therapeutic alliance. I also want to showcase a study that was conducted by our own consumer advisory board at the Massachusetts Mental Health Center, where I'm speaking from. A group of individuals with lived experience of mental illness contributed to this study, and they jointly developed a scale for measuring therapeutic alliance called Treatment Relationship Inventory, or TRI, and found that the higher the therapeutic alliance, the stronger the therapeutic alliance, the better was the quality of life in patients with severe mental illness. Now, how do we share diagnosis and the prognosis with our patients and their families? This is another important aspect of the art of care. Now, let's look at this, and please feel free to put in the chat what might be the wrong things in this way of presenting the diagnosis to a patient. A patient has been diagnosed with schizophrenia, and so when the patient asks, what is my diagnosis? And this is what is the statement. So you're suffering from a chronic schizophrenic illness. It's a condition that is a medical term for what lay people consider craziness. Any thoughts? There's almost everything wrong with this statement. Words matter. Suffering from. The patient may not even agree that he or she is suffering from an illness because they may not have the insight. So that's probably not a right way, thing to assume that they are suffering or they think that they have an illness. They may not be having that insight. The word chronic has its own repercussions. Chronic means it is a state accompli that it is a chronic illness. But the fact of the matter is that schizophrenia and other mental disorders are highly heterogeneous. Some of them are episodic, some of them are chronic, some of them have one episode and don't get a relapse. So to assume that somebody has a chronic illness would also be a mistake and is likely to create a disheartening perception among the patients. Schizophrenic. Again, the word schizophrenic sounds more like an adjective. It is better to say someone has a schizophrenia as an illness. You have a diagnosis of what appears like a schizophrenia or related illness is a better way of putting it. And always one should avoid loaded judgmental terms like craziness or insanity and so forth. Even the term schizophrenia is not acceptable to many people because it has become so stigmatized over the course of the last half a century. Recently, we conducted a large survey of over 1,100 individuals, multiple stakeholders of various kinds, patients with illness, caregivers, family members, treatment providers, and so forth. 74% of them prefer to change the name schizophrenia to something else. And the most prevalent alternative that was actually suggested by one of our consumer advisory board members. And the most popular alternative title was altered perception syndrome. It is easy to see why this is the case because perception is something we all have as a function of our brain, and it is not easy to stigmatize perception, just like any other function of what we do. So it's something that the field has to seriously consider whether there are satisfactory alternatives for the name schizophrenia. We don't have a good answer for that at this time. This is a paper by Raquel Meshulam-Gately, who you just heard. Worth reading, this paper that recently appeared. It's important to use normalizing, hopeful language. Instead of saying, for example, you seem to be having paranoid thoughts, it may be worth considering saying, it seems you have difficulty trusting people. Instead of saying you may be unable to go back to work because of cognitive impairment, it may be better to say you may have difficulty concentrating at work at this time. Exactly tell them what they have instead of making it a label of being impaired. So they may have trouble concentrating, which is easier. They're probably more likely to accept that. And also to make a statement that seems to have seems to ring permanent, such as you may be unable to go back to work. Instead of saying that, you may have difficulty working at this time because of the concentration problems. Instead of saying you will have to be on meds for life, it might be better to say, for now, it would be good to continue meds for at least a year, and let's make sure that you don't relapse, and let's revisit that in a year. So it might be a better approach. Now, we came up with an acronym to summarize the key points for how we share diagnosis with our patients. It needs to be individualized because they all come with different biases and prior knowledge or opinions and attitudes. So one needs to tune into what the patient already comes with and individualize the way we present the diagnosis to our patients. And also using normalizing language, mistrustful rather than paranoid is an example, as we talked about. Language that is non-stigmatizing. And also consider the specific in which you're talking about the diagnosis. Is it with the patient alone, or is the family also there? What might be the family's own biases and prejudices about hearing about a diagnosis? Are the other treatment team members there as well or not? And consider the setting, that's important. It's important to also present the diagnosis in a person-centered way. To define this as a part of an illness that would fit in and help understand the patient's own situation in a person-centered way. Provide accurate and comprehensive information that the patient is able to accept and also process and digest. It's always important to be reassuring when we provide the diagnosis. And thankfully, in psychiatry, the majority of psychiatric disorders, do respond to treatment of some kind or the other. So it's important to get that up front. It's important to be empowering and empathetic at the same time. And also, whenever we present diagnosis, it's important to give them an outline of what the next steps are. How do we work together as a team to get you better from this? Is the kind of approach to take. It's called the INSPIRES approach that is similar to the approaches that have been articulated in the rest of medicine in other fields, like in cancer and in chronic joint disease and so on. Also, patients and families often come and ask the question, what's the outlook, doc? How should I change my life to care for my son or daughter? What's the prognosis? So again, the same principles are very important. And I would call it the hope principles, that is providing hope, but at the same time with honesty, and humility, because we cannot know everything. If we don't know, it's better to state our ignorance. But at the same time, also point out that over time, things might become clear. But at this time, given what we know what the treatment would be, and treatment will certainly help. Over the course of time, we may be able to come up with a better sense of how things will be in the longer run. And also, it's in my practice, I bring up therapeutic options that may be down the road, but I bring them up early anyway. For example, with someone with a diagnosis of schizophrenia, rather than bringing up the idea of, say, a long-acting injectable 5 years down the road after the patient has had 3 relapses, I might say, we will start with you with an oral medicine, but we'll see how things go. Some people, often for various reasons, including side effects and so on, may not take the oral medications. So there is another option which comes as an injection once a month, or once in 2 months, or once in 6 months, once in 3 months, and so on. Keep that in mind, and we'll bring it up later if necessary, and so on. So bringing up the option early on, and also alerting them to the possibility that non-adherence can happen early itself, and acknowledging that possibility will actually give the patient a kind of a safe corridor, if you will, to share with you any non-compliance that they may engage in during the course of treatment. Oh, doc, I forgot to take the medicines. And you were right that sometimes I forget, or sometimes the side effects are too much for me, and so on. Talking about prognosis also needs to be person-centered and partnership-focused. For example, this illness is likely to relapse and remit, get better, but also may have a tendency to relapse under stressful situations, but we'll work together to minimize those relapses. So always provide the prognostic outlook with a partnership and a plan and an empowerment, so that from the get-go, letting the patient know that he or she has a role to play, and that we are a team with the patient. So here is a person who has schizophrenia, who wrote about her own experience of being told about the outcome of schizophrenia. She was told, is a well-known person, by the way. She is a famous schizophrenia researcher down the road, even after she recovered from schizophrenia. She said she was told, you have a disease called schizophrenia. Schizophrenia is a disease that is a lot like diabetes. Just like a diabetic who has to take insulin for the rest of their lives, you will have to take antipsychotic medication for the rest of your life. After discharge, this doctor said, your job is to avoid stress and to take high doses of antipsychotic and religiously in order to slow the progression of the disease. No romance, no school, just avoid stress. So Pat Deegan, who wrote this paper, just then says, no one at the time told her that boredom and meaninglessness can be profoundly stressful. So it's easy to say, avoid stress, no school, avoid getting back to work at this point, and so on. But then we have to tune in and think about how the patient would perceive that. So this is very important. It speaks to the principles of person-centered narrative of how we talk about diagnosis and prognosis to our patients. The third point is, how do we develop a shared decision-making approach in the management of psychotic disorders? Now, this usual approach to care is what is called paternalistic. The clinician has all the answers and provides the answers to the patient. It's a unilateral, hierarchical, one-way street. By contrast to that is and also the clinician provides the information to the patient and the decisions because the clinician has the knowledge and the skills to do so, and so on. This is a paternalistic approach. By contrast to that, the patient who has more knowledge than us, the clinicians, about his or her illness. We may know more about an illness, but they know more about their illness. So it's important to develop a team approach. So shared decision-making is something that sits at the center of patients' own perceptions of goals and preferences, the clinician's knowledge of and evidence-based medicine and expertise, and the biological and psychosocial context. That is shared decision-making. Shared decision-making, several studies have shown that it improves patient satisfaction, better adherence to treatment plans, greater treatment engagement, and also higher quality decision-making. So let's think about a case. This lady, 38-year-old woman, treated as an outpatient for schizophrenia, has recurrent relapses and hospitalizations, despite treatment with 3 atypical antipsychotics. Last year, she was treated with clozapine because of treatment resistance, and that did help. However, there are side effects. She's troubled by excessive sedation. So now she wants to say, I want to stop clozapine, doc, because she's afraid she may lose custody of her 3 children. She's not able to take care of them. So what would be your response? A, strongly recommend continuing clozapine since she has not responded well to 2 other antipsychotics. B, discontinue clozapine and start her back on her previous medications. C, discuss with her the pros and cons of discontinuing clozapine and present her the options of continuing clozapine plus modafinil, an alerting medicine, or a trial of an alternative antipsychotic with less sedating effects, such as lurasidone. Let's see. How many of you choose option A versus B versus C? Chat box.
It looks like the majority are choosing C.
Yeah. So again, you're all experienced clinicians, and so you all know that the key principle is to use a shared decision-making approach, as illustrated by this case. The 4th point I want to bring up, which is a larger point, is the key principles of psychopharmacology. I'm sure there are many prescribers here who would benefit from these principles. Dr. Carl Salzman is here. He and I wrote a paper some years ago called the 7 Commandments of Prescribing. And so I added a few more. This is the 10 commandments. Coordinated treatment plan, connecting and consent, comprehensive assessment, the right choice of medications, the right dose and duration, making sure compliance or adherence is ensured, collaborative decision-making, which we already talked about, consider comorbid medical disorders, check and prevent side effects, and also, whenever in doubt, obtain a consultation. Now, I show this slide because this is a talk about early course psychosis. There is increasingly a paradigm shift in the field to provide care for people with the first episode of psychosis in a coordinated team-based setting, where a number of clinicians across multiple disciplines, psychiatrists, social workers, peer therapists, psychologists, and family therapists, and internists, and nurse practitioners, and some employment therapists work together to improve outcomes in a team-based manner. So that's a very effective approach, and studies have shown that this kind of a team-based approach is superior to treatment as usual. We already talked about engaging, developing a therapeutic alliance, the LEAP principles, and the Xavier Amador book. I won't go into the details again. Comprehensive assessment, which is critically important. One should always have a working diagnosis at the beginning, and which is based on a careful history, examination, review of previous records, collateral history by family and other caregivers, review of previous treatment response, review of previous treatment compliance, and obtaining lab results as needed. So all of that information, the earlier, the better. Choosing the right treatment. It's important to aim for overall remission, not just symptom improvement. Choose the antipsychotic with the most favorable side effect profile. As I'm going to show in another slide, most antipsychotics, with the exception of clozapine, work about similarly. So often the choice of the medicines is based on what side effects that the patient would not prefer to have. and so on. In first episode psychosis patients, thankfully, they respond well, almost 80% of them, to smaller doses, almost like half the dose of what you see in multi-episode schizophrenia. At the same time, first episode patients are also more sensitive to side effects. Monitor their side effects closely, monitor for medical comorbidities because they accrue over the course of time. The earlier one catches a subtle degree of weight gain or glucose dysregulation, the better in the longer run. And more using patients' own self-ratings to get all the information to make the best decisions based on what is called a measurement-based care approach would be helpful. I won't go into too much of the science of prescribing in this talk, but suffice it to say there are a large number of medications that are available, broadly classified into the so-called typical and atypical antipsychotic drugs. They have all their advantages and disadvantages. By and large, these days, atypical antipsychotics are the go-to choice when treating a first episode psychosis patient. And a good number of them do not have the metabolic side effects that some of the earlier ones did, like risperidone and olanzapine. And also, the atypical antipsychotics have relatively less extrapyramidal side effect potential and less prolactin elevations. I already mentioned these principles. They respond to long monotherapy trials, and those requirements are lower. Compliance is very important, and if not treated with continuous treatment, within 5 years, almost 80% of them relapse. And relapse often leads to not only hospitalization, but also loss of life opportunities and loss of income, loss of employment, and perhaps also worsening cognitive decline. And so it's important to prevent relapses using long-acting injectables and so forth. Check for side effects. Preventing side effects by careful history and appropriate choice, early monitoring, and psychoeducation are critically important. Consider switching antipsychotics versus adding side effect medications, because the tendency often is to keep on adding medications as opposed to considering an alternative that might work better. Comorbid medical disorders are highly common. As you see here, lipid elevations are very common. Almost 50% of patients with psychosis treated with antipsychotics have hyperlipidemia, and over 50% of them smoke, and about 10% in the first psychotic episode already have high blood pressure, and diabetes risk creeps up over the course of time. As you see, majority of them remain untreated, even in the chronic courses of illness. Patients with severe mental illness end up being undertreated for medical disorders. Tailoring treatment to the phase of illness. As I had mentioned earlier, schizophrenia is a phasic illness with a prodromal phase, a psychotic phase, and a chronic stable phase with persistent symptoms. And illness typically begins in adolescence. Functional decline begins during the prodrome. And after the first psychotic episode, recurrent episodes may occur, and other problems might get added on, including mood disorders, treatment resistance, and cognitive impairments. In the prodromal phase of the illness, which is characterized by functional decline and subtle subthreshold psychotic-like symptoms, the approach to treatment is not antipsychotics, but close monitoring and perhaps psychotherapy and stress reduction are valuable. In the psychotic phase, the approach is we already, of course, we had to make an appropriate diagnosis. We need to ask the right questions. Is it a psychosis? Is it is there an underlying medical condition or a substance use disorder? Is this psychotic illness better explained by a primary psychotic disorder or another mental disorder like bipolar disorder or PTSD or a personality disorder? So these are the kinds of questions that one needs to ask. So as I said, all antipsychotics, with the exception of clozapine, work about similarly. So side effects have to guide us with regard to the right choice of treatment. And this is too busy a slide. I won't go into too many of these details. I'll have these slides available for people. There are many available second generation, third generation antipsychotic drugs with these kind of side effect profiles, as you see here. We already talked about the chronic phases of the illness. Because of time, I will skip some of these concomitant problems like marijuana abuse, which is increasing because of the liberalization nationally. And also the THC concentrations are increasing nationally as time goes by. And many patients, over 40% of our patients with first episode psychosis have a current or chronic past cannabis habit, and nearly 80% have some degree of exposure. Given high prevalence, it's often difficult to say whether psychosis is caused by or simply comorbid with cannabis. In our own data, we have seen that the typical age of cannabis onset, abuse onset, is around age 14, and the typical age of psychosis onset is around age 19, with about 4 to 5 years interval between those. Heavy cannabis users, the approaches to try include flexible needs-based treatment. Sometimes motivational interviewing can help, family psychoeducation, contingency management, harm reduction approaches, using strains with high cannabidiol levels. And also there is a lot of work that is needed for policy advocacy to establish THC potency limits, ban preparations that are attractive to children, and so on. Another important approach in the caring for psychosis is to consider family and engage the family from the get-go in terms of treatment. Quite often, there are family-related stresses that could lead to contribute to relapses. And there is this large literature on what is called critical emotions or high expressed emotions. Families which are over-involved and families which tend to be highly critical tend to lead to worsening of psychopathology, whereas non-judgmental families and supporting individuals' autonomy can be quite protective. And so family psychoeducation can be helpful if instituted early on. I already talked about non-adherence and the use of long-acting antipsychotics. A lot of them available now with 1 month, 2 month, 3 months, and 6 month preparations. And clozapine is an option available for those who do not respond. About 1/3 of individuals with psychosis do not respond to standard antipsychotic drugs, and about 2/3 of those, one third, do respond to clozapine. And another aspect of the art of taking care of individuals with mental illness, and this is true of all of medicine for that matter, is to avoid what we call cognitive biases. There are many biases in our practice. We kind of close our minds and lead our minds to go in the wrong pathways because of a number of these biases. One example of that is what is called confirmation bias. Since the patient has this diagnosis, you start looking for all evidence that would support that this patient has this particular diagnosis and ignoring many lines of evidence that might suggest otherwise. Another kind of bias is what is called anchoring bias. So from the get-go, I thought that he has schizophrenia, so he must have schizophrenia. So make up your mind kind of too early, and then not open your mind to options that it might change down the road. Availability bias. I remember seeing a similar patient with this diagnosis. So this next patient must be having the same diagnosis. So this is what happens if you work in specialized clinics. Everybody who comes into the clinic must have that particular diagnosis and so on. So consider watching one's own thinking patterns and be aware that we could get into this kind of cognitive traps. So in summary, the key points of a caring for psychosis and the art of caring psychosis include developing a positive and a sustained therapeutic alliance, sharing the diagnosis in a person-centered, hopeful approach, sharing the diagnosis as well as prognosis. Also, provide autonomy to the patients and use shared decision-making. There is a science and an art to prescribing. Tailoring the treatment to the individual patient and to the phase of illness are critically important. Finally, watch one's own thinking and avoid cognitive biases. So I think that's my last slide. And I'll stop there. These are my funding supports and my disclosures. And I'll stop my slides so that people can see each other, and I'm happy to answer any questions.
Well, Dr. Keshavan, I wanted to start by thanking you for this incredibly important, informative, helpful, and engaging presentation. Just reminding us of a lot of important principles regarding the art of treating people with psychosis, as well as providing important updates about the science as well. I did see during your presentation, there was a variety of comments and questions that popped up in the chat. And I was wondering if those people might want to unmute themselves to ask the questions on their own. I see one from Monica Reusner and Linda Cottrell, and there's a few other questions coming in too. So Monica, would you like to start by asking your question?
I can see the chat box, and I'm happy to bring up questions from here and answer them in the order they appear. So Monica Reusner said this was in response to another podcast she had with Freddie DeBoer, who talks about the opposite side of things. So this is more of a reflection rather than a question. So we'll leave that. Linda Cottrell asks, due to impact of multiple psychotic episodes, is cognitive decline permanent, or can the patient get back to previous baseline? So it's an extremely important question. Now, the good news is that cognitive decline does respond to treatment. That's because of the brain's own power of what we call neuroplasticity. And with the appropriate cognitive remediation and training, the majority of individuals with cognitive impairments can get some benefit, which may range from mild to moderate to large benefits. But can individuals get back to their previous baseline? That varies. It depends on how well the treatment is adhered to, and how lifestyle adjustments are made to increase exposure to cognitive opportunities. So there is improvement in a majority of individuals with cognitive remediation treatments, but there is variability in how much people can get back to a baseline. Again, it depends on what the baseline is. So if you consider baseline as just before the first psychotic episode, that's different from, let's say, the baseline in childhood. would they get back to how they showed their intellectual abilities in childhood when several years have passed in terms of the illness? The answer may be, it may be variable. Will they get back to their level from their first, what they showed at the first psychotic episode? The answer, I think, based on research and my own experience, is absolutely yes. They can get back to that. Leah Hunter asked the question, this is exactly what we're seeing. Can we get a copy of the slides? Absolutely. Slides will be sent out. It happens a lot. Thank you for all the positive feedback. Do you recommend alternate or complementary treatments to address trauma, etc.? By complementary or alternative treatments, what do we mean? If it is complementary pharmacological treatments, there are some that are out there with partial evidence or modest evidence, which are safe and worth trying, but you can't have too much of an expectation because they're not established. One example is what's called N-acetylcysteine, NAC, which is available in nutrition stores. And then there's the omega-3 fatty acids and so on. And there is a glycine. There are a number of these options. But be aware that they may or may not produce large effects. And as long as you moderate your expectations, they are by and large safe interventions. I will be sending out. Let's see. I think that those are the questions that I see here. Any others that people? Let me see. Any that I missed?
Yes, I just have one. Thank you so much for this. This is great. I saw on the slide that when you were posting the information about marijuana, I saw just 2 words saying CBD okay or is okay. And I was wondering if you could elaborate on that, like what you meant by that and what research has shown.
Yeah, it's a very good question. CBD, also called cannabidiol, is a component of marijuana, and increasingly in the United States and elsewhere, cannabis preparations that are available have increasing concentrations of tetrahydrocannabinol, THC, which is the more toxic one for the brain. On the other hand, cannabidiol, in a number of studies have shown, may have some potential benefits, and it's definitely not related to triggering psychosis. There are 2 studies that have shown that in randomized controlled trials, cannabidiol may produce some moderate degrees of benefit for schizophrenia. And in fact, we at Beth Israel may be going on. Bill Stone in our group will be doing a study going forward on that in people with that clinical high risk for psychosis. The final word has not been said on CBD, but it is worth considering. Once the results become more established. At the very least, what I tell my patients is, if they're bent upon smoking marijuana, I'll say, at least can you go try and find a preparation that has a high concentration of CBD. I don't tell them to necessarily use CBD, but I tell them if they're going to use cannabis, they might as well use something that is a more benign version of cannabis.
Thank you.
Yeah.
Yes, I see there's a question from Ken Farbstein. Ken, did you want to unmute yourself and ask it on your own?
Okay, sure. Thank you, Becca. Yeah, Dr. Keshavan, thanks very much for your presentation. And I'm wondering, for people who are well into their recovery from psychosis or from schizophrenia particularly, is there an evidence basis on how to taper off this one of the second generation antipsychotics?
Yeah, so that's a kind of a difficult question. If someone is well recovered, how does one go about discontinuing the medication? That's your question, right?
Yes.
So I have been in this situation where patients have asked me to discontinue treatment after being well for, say, 1 year, 2 years, and so on, and have had only one episode. What I tell them is it may be worth a very gradual dose reduction. And the question of complete discontinuation is something that we will figure out as we go forward. And having said that, then what I do is drop the dose maybe by 10% every 3 months. And the majority of individuals who have schizophrenia, probably over 80% of them, begin to show signs of relapse during that dosage reduction period. And a small proportion, maybe I would say about 10%, might do fine over years without antipsychotic on board at all. And that proportion is so low that over the course of time, I have learned to be cautious. But a minimum maintenance dose is the best strategy. Yeah, it has to be balanced again on the issues of side effects versus efficacy. If someone has been on an antipsychotic with more side effects than beneficial effects, I would be more likely to, begin discontinuing and maybe consider an alternative for such an individual. But it's hard to make a generalized statement on a question like this. It has to be a case-by-case basis. It also will depend on the diagnosis. Schizophrenia is quite heterogeneous. There are a number of disorders that look like schizophrenia, but may be more short-lived. Maybe a drug-induced psychosis, where there is a question as to whether this is not a primary psychosis, whether this is a bipolar disorder which presented with a psychosis, and so on. So in such situations, the decisions are going to be different.
Thank you.
Yeah.
And it looks like we're out of time or over time already, although I'm sure we could have continued speaking or asking questions for a lot longer. But I wanted to thank you so much again, Dr. Keshavan, for presenting today, and thank everyone for attending today's webinar. And Lola, I know there's a few housekeeping items that you wanted to quickly bring up as well.
Yes, I sent a post-event survey in the chat. If you all could just fill that out, that would be great. And I will also be sending it out via email shortly after this.
Great. All right, thanks everyone.
Thanks.
Happy holidays.